Well, I want to welcome everybody to our Transplant Institute lecture today. My name is Marwan Abeljoud, and I'm the director of the Transplant Institute. Today we have a great program for you, and it's actually one of the more unique lectures we've had this year and from past year too, because it revolves around something we all encounter on a daily basis. Transplant is in the business of saving lives. We deal with patients and families, and they encounter or see risk of mortality or mortality and vulnerabilities. And then when they get transplanted or not, there is always challenges to the news that they deal with. And there is no neutral news in transplant. Positive news is great, it's easy, but the rest is always loaded with emotions. And today we're lucky to have our duo, Dr. Anita Patel, who's the medical director of the Kidney Pancreas Transplant Program, and also Dr. Eshelman, who is our senior transplant psychologist, and I would say she has been with us so many years that she officially would present herself as the director of Transplant Behavioral Sciences. That's a new title. And so without taking much of their time, they've agreed together to pair up so they can present this concept and maybe engage into dialogue that will get us more into this theme. Thank you much, Anne and Anita.
Thank you.
And this is for you, right?
Welcome, and thanks for coming. I know it's a busy Monday. These are our objectives. I think it's important to think about how this came up. And one of the impetuses for this was that, well, actually, Dr. Abeljoud asked us to look at this and apply what's known in the literature about communicating bad news in the context of transplant. And there's very little specific to transplant. There's a large literature in oncology, and that's a specialty where bad news is a many times a day type of occurrence. These are our goals. We're going to present a protocol that's developed from oncology and applying that to our transplant population. So what is bad news? It's any news that drastically and negatively alters the patient's view of his or her future. So why do we need to learn how to do this well? Well, one of the things that initiated this was sometimes it's not done well, and when it's not done well, it can be extremely stressful for the messenger. It can be extremely stressful for the patient and family. We want to prevent misunderstanding and future problems. But Anita's going to share with all of us an interesting case that was what initiated this seminar, where someone was turned down for transplant, and her sister got very upset and was on Facebook saying bad things about the hospital and discrimination and all kinds of things, throwing around things with her 3,000 friends on Facebook and threatening to go to the media. And we want to learn how to do this effectively so that we don't have that kind of very, very stressful situation. Giving bad news well can strengthen the doctor-patient relationship, fosters collaboration, and it gives the patients and families a chance to really understand and develop plans and cope. It also may prevent lawsuits. And we don't do this because we want to prevent lawsuits, but I think it's good to look at why people sue. I went to a conference at Harvard a couple of years ago on legal and ethical issues in healthcare. And one of the studies that was presented was asking people after a bad event, an adverse event, how did you decide if you were going to sue or not? And I think that's important. But anger is part of it. When they're angry, they're more likely to sue. If they feel like there's a we-they relationship with a doctor that's adversarial, if they see doctors as arrogant, if they feel like they're abandoned, if they feel like somebody needs to pay them for their pain and suffering. But interestingly, for every 7.6 incidents of adverse reactions or negligence, there's only one lawsuit. So that even when bad things happen, people don't always sue. And I think being able to give bad news or be able to talk about negative things in a way that is supportive of the patient and helps and respects them, and following this protocol can make a difference in maybe somebody deciding whether or not they want to sue. So why is giving bad news hard? Well, nobody likes to give bad news to anybody. I mean, you don't like to tell your children or your spouse that they can't do what they want to do. You don't want to give anybody bad news about anything. You don't like to be a messenger of bad news. But I think in transplant it may be especially hard because I think people who choose to go into transplant, it's kind of a rescue specialty. We like to give people chances. We like to have positive outcomes and things like that. And when things don't go well or when we have to give bad news, it may be especially hard. Also, when people don't feel prepared and they don't really know how to do this, probably everybody in this room at some point has had to give somebody bad news, and you might think, boy, I'd rather leave that to the end of the day. Maybe somebody else can do it and I don't have to do it. Maybe I'll just go in, say it real fast, and leave before they have a chance to ask any questions. So I think somebody's had this before. So there's an avoidance that because it's uncomfortable and it stirs up emotions in people. Also, it's time consuming. And we've got a very busy schedule, but this isn't something you can do in drop the bomb and leave in 2 minutes. It can be very time consuming. But if you do it right, it's probably less time consuming than if you do it wrong. It's also emotionally draining because patients respond in all kinds of emotional ways, and we feel their emotions. We have negative feelings and feel bad when we have to give bad news and when they react with all kinds of emotions that are difficult to deal with. Also, this may stir up our own issues with having been given bad news or people in our families or things like that we may have unique issues around this as well, and it's probably good to look at that. So what do patients want? They want a positive attitude and that they are working together. They want a clear message. They want privacy. They want this to be done not in an open place, but a place where you can sit down and talk. And they want their questions answered. These are some of the major examples of bad news in transplant. And when we were asked to do this talk, we decided to do a couple of focus groups. So we met with transplant coordinators in January and talked about the kinds of bad news that they have to give and how comfortable or uncomfortable they are giving that kind of bad news, and why this is uncomfortable for them. We met with transplant physicians and surgeons also to talk about the kinds of bad news that they have to give and how it should be given. So these are some of the things that are predictable. And we'll be talking today about a 6-step protocol that may make this go more smoothly. The first step, and this isn't in the 6-step protocol, is having realistic expectations. Because if patients' expectations are too high, for example, they think they're already listed for transplant, then getting bad news like a turn down is going to be even more difficult. If they know that bad news is possible and they're going into this situation, then they may have thought about the whole range of possibilities in a better way. Also, in terms of who should give bad news, the doctor-patient relationship is really important. Some of our patients live far away and we don't see them very much though. And there's some situations where the coordinator may have a better relationship long-term with the patient. In some situations, the physician may not really know the patient very well. And those are things to consider in terms of who should be delivering the bad news. So thinking about who's the best person to deliver bad news is important before this 6-step protocol. And we need to think about within each of the teams. In our focus groups, it seemed like the different transplant teams don't have the same protocols for giving bad news. And in some transplant teams, the turn down is given by a physician, and in some it's given by the nurse coordinator. And in thinking about should we be doing it the same in all the transplant teams, we sort of came to the conclusion that each team really needs to look at what are the issues within that organ team and come up with what should be delivered in letters. And letters really should be a follow-up or something that's expected, not surprise letters. And what information can be given by phone, and what should be given by the nurse coordinator or the attending physician, or maybe the referring physician has the best relationship long-term with the patient, and certainly they need to be in the loop, but there may be some kinds of information that they should be giving. But each team needs to review their unique issues and determine their own protocols. In the 6-step protocol, the first step is called setting, and we call this the spikes protocol. You can remember the word spikes because it's setting is the S. It's important not to give bad news in a busy waiting room. You want to have a quiet time where the patient is ready, that you've done your homework, you've reviewed all of the medical information, you've thought about the options, you've talked with other members of the team so everybody's on the same page. It doesn't look good if somebody gives bad news and then somebody says, well, it's not so bad. You know, we need to be on the same page so that the patient is getting consistent information and they feel like we are working as a team. It's also important to anticipate the patient's questions. Think about if you were in that situation getting this information, what questions would you have? And it's usually pretty easy to predict what their questions are and then be prepared for those answers. If you predict and be prepared for those answers, you're going to feel much more confident when you go into it so that you're not fielding from left field. Also, we work as a team, and we do have support staff that may be helpful. There may be certain circumstances where my team should be involved. You know, when the patient has said, if I get turned down for a transplant, I'm going to kill myself. Well, you know, that's kind of in our area. In some circumstances, the social worker may have a very good relationship with the patient, and they may need to be in the room when the news is given, or certainly available for follow-up as needed. The second step is the perception. We need to know what the patient has been told, because if we just go in and drop a bomb, we don't know if they were expecting, you know, what they were expecting. So what have you been told about your condition? And if they are telling us in their own words, they're communicating what they already know, which may or may not be accurate. And we may need to clarify that before we begin with any new news. So we want to know what have they been told, what's their understanding. We also need to look at, are there any limitations on what they can understand? Many of our patients have encephalopathy for various reasons. We have liver patients, kidney patients, lung patients who have cognitive deficits related to the illness. Some have psychiatric conditions, some can't read. And it's important for us to know what's going on with our patient and are there any limitations. If we give them the news and we're thinking we're doing a great job, but they didn't get it or they left the room with a different message, that's important, and we need to use kind of a teach-back approach, checking for understanding to make sure that they actually got it. Even if there aren't any cognitive deficits or psychiatric issues, with bad news, people are overwhelmed, and there's lots of emotion. They're anxious, and there may be physical pain, there may be emotional pain, but when people get really anxious, they may hear something like the word cancer and then shut down and don't hear the rest of it. You've probably seen this in movies where somebody is sort of talking and it's like they just can't get the information. If you're not ready or if the patient's not ready, it may be important to reschedule at a better time rather than trying to go ahead and have the discussion if it's not the right time or they don't have the right support. And we know our patients pretty well, some of them, where sometimes there's a spouse or an adult child who is always with them. If that person is a key person and the patient wants them with it, we may need to reschedule till that person is available. The next step is invitation and sort of beginning with, I want to talk to you about your illness, or there's some things we need to discuss. So that opens it a little bit. We also want to know how much the person wants to know. We do have some patients who just sort of give me the details in the plan. We have some who want lots of information, and we have some with, don't tell me, tell my son. And I think we need to know how much they want to know and give them little bites so that they're able to process each before they go on to the next step. Different people handle information differently, and there may be issues as far as ethnicity or culture or their own experience with medical information. The next step is actually giving the information, knowledge. So unfortunately, I have some bad news for you. Saying it simply and clearly, and then stopping. Not stop and leave and hope that they don't have any questions, but stop and wait and be able to listen and give them some time to react. Now, this is a tough time because some of their reactions, they may blame you for giving bad news. They may be angry, they may be upset, they may burst into tears, and this is uncomfortable being in the room with somebody with this high level of emotion. But staying there and being with them while they're very emotional is really important. And it may feel like it's going to last forever if they're yelling or crying, but typically if you're still and quiet and you're there with them, they settle down, and then you can ask, are you ready to talk about the next step? Make sure that you're not glossing over things so that they're euphemisms or jargon that they don't really understand, and check for understanding. There's been some research on should we be apologizing or saying I'm sorry, and it used to be like 20 years ago that don't say you're sorry because that sounds like you're responsible and you're more likely to get sued. Actually, there's a lot of research out of University of Michigan with their Institute of Social Research looking at when people say they're sorry, rather than feeling like you're accepting blame, it's you're sorry they're going through a hard time, you feel something for them. Patients actually really appreciate that. And we are sorry that they're going through something and they have to get bad news. So you don't have to avoid saying you're sorry. So the next step is empathizing or empathy, saying I'm sorry to give you this bad news, and then responding to the emotional reactions of the patient. The next step is shared decision making. Are you ready to begin discussing the next steps? Now, this may not be in the same visit. It may be, give yourself some time to let this settle in and to talk with your family about what questions you have, and let's schedule a second visit for the decision-making part. But that involves what are we going to do next? What is the next option for treatment, symptom management, any referrals, potential resources for support. Also, it's important at this point and along the way to assess the safety of the patient. And you may want to make sure that they have somebody with them. And certainly if somebody has a psychiatric history, we want to be especially careful of our safety. Well, I'd like to pass this off to Dr. Patel. This is our spikes protocol. You will be getting a handout because I think this makes it easy to remember these steps. Dr. Patel is going to show an interesting video that I think brings these steps clear, and also she's going to show us how she was able to really resolve or really help the situation when a patient did respond very badly to bad news. And each person will develop their own style, but I think she's got a wonderful style and patients respond well to her. She'll also share with us how she has looked at giving bad news in the context of kidney transplant, and we'll be looking at each team and how they can give bad news in the context of their own issues. So.
This is a little video, a clip which we saw and took some time to think which one should we show. And I thought this is really good because it explains two different aspects of the same process.
Hi, Doctor.
Good to see you again.
You too.
How are you doing today?
A little anxious.
A little anxious? We did the biopsy yesterday on your pancreas, and we saw something funny there. And the biopsy came back, and it did show that there was a tumor. Now, this is serious, that there's a tumor there. But there are things that we can do about it. Um, I'd like to set up an appointment for you to see a surgeon, and probably also an oncologist.
Wait, doctor, do you mean, excuse me, do you think that this is cancer? The tumor is cancer, you mean?
Yeah, tumor means this is cancer. But there are many things that we can do for it. A lot of experimental things going on. I'd like you to see one of the surgeons and also one of the oncologists, and probably want to talk to you about some chemotherapy and what the options are there. Those are kind of the main ways that we deal with this kind of a problem. Do you have any questions?
Oh, I have a million questions, but I don't even know where to start.
Yeah, that's real common when this kind of thing happens. Not surprising. Maybe it'd be a good idea if you saw one of our psychologists here. They can help you with that.
I don't know about that.
Oh, just a minute, excuse me. Got a message coming in. Listen, why don't you think about things? I'll set up the appointments for you to see the oncologist and the surgeon. Think about whether or not you'd like to see a psychologist, and give my office a call next week. And I'll see you later. I'll send my nurse in to make those appointments with you.
Okay, doctor.
Okay. Hi, Miss Johnson.
Doctor.
How are you today?
Well, I'm a little anxious.
Yeah, how did the biopsy go yesterday? Was it real painful?
No, it was okay. It wasn't too bad.
Okay. Anybody here with you today, or are you alone?
No, I'm by myself.
Okay. Tell me what your understanding of why we did the biopsy yesterday.
Well, they found something abnormal around my pancreas, and they wanted to check it out and see what it was.
Okay. I've talked to the pathologist, and I've gone over the slides with them, and I'm afraid there's some bad news. I'm afraid that, I was concerned that this might be cancer, and it was.
Oh, my.
Can you tell me a little bit about what's going through your mind? Is this a huge surprise? We sort of discussed the possibility yesterday.
Does this mean I'm going to die?
Well, we saw the abnormality on your pancreas, and it also looks like the cancer is in the liver as well. This is not a curable form of cancer with any treatments we have right now.
Oh, my gosh. All I can think about is my parents. They both died of cancer. I just seem so hopeless.
Yeah, I hear you. It may feel hopeless. There are things that can be done. There are treatments available that can potentially make you live longer. Would you like to talk about the treatment options now? You feel like you're up to that?
I think I need to wait and just kind of think about what you just told me.
Okay. Would you like, we could set up an appointment later today, tomorrow morning. Perhaps you can bring someone. Is there somebody in your family who can come with you?
Yeah, I think I should have my children meet you and talk to you too.
Okay.
Maybe tomorrow.
Okay, we can set up a time tomorrow
Okay.
morning. What I'd like you to do is go home, and is there maybe somebody who could be with you today even, and talk about things? And as this is going through your mind, think about, write down all the questions you have, and we can discuss it tomorrow. We can talk about what the different options are. I want to let you know that, I'll be with you throughout this.
Okay.
I've been your doctor for a while, and I'll be involved through whatever happens. And we'll do this together.
I appreciate that.
Okay. We'll see you tomorrow.
Okay.
Okay. Hi, Ms. Johnson.
Hi, Doctor.
How you doing today?
Well, I'm pretty tired.
Are you? I got the report back on the CAT scan you had done yesterday. I went over it. It looks like the cancer's getting worse. The nodules on your liver are definitely getting bigger. Now, you know, you've had the radiation treatments and you've had two go-rounds of the chemotherapy. I did call the oncologist. We talked about the situation. He said there's definitely more treatments available. There's some more chemotherapy that can be given, and even if that isn't working well, he said there's some experimental treatments that would be possible over at the university. So I think that would be the next move. Would be doing more treatment. What do you think about that?
I don't think I can even think about that right now.
Yeah, well, that's normal. It's to be expected to feel that way and be upset about the results of this. I would really encourage you to go on and take some more treatment. I've talked to the oncologist. It sounds like a reasonable thing to do. I think it might help give you some more time. So why don't you think things over? Give me a call next week, and I can set up an appointment for you to see the oncologist.
Okay.
Okay. Take care.
Bye. Come in.
Hi, Miss Johnson.
Morning, Doctor. Hi.
Hi, good to see you. Tell me how are you feeling today? How's it going?
Well, I'm pretty tired. Been feeling pretty lousy since that last chemotherapy. It was really rough.
You had the CAT scan done yesterday. I did get a look at it yesterday, and I wanted to kind of review the results with you. I'm afraid it's not good news. Yeah. CAT scan shows that the tumors in the liver are getting bigger.
Oh, jeez.
It looks like the chemotherapy you've been getting is not doing what we had hoped it to do. Does this surprise you?
No, it really doesn't. I think I suspected that. I had been feeling lousy and really didn't thinking that chemo was working very well at all.
There are still some other options we can talk about in terms of different treatment options if you want to talk about them now.
Well, what happens if I don't get any chemotherapy? I mean, how long do I have to live?
Yeah, there are really two main options that I see right now. One is doing some more treatment, more chemotherapy, and I did talk to the oncologist, and he said that you've had kind of the standard treatment. There are other treatments available. There's even some experimental treatments. And like always, I know the chemotherapy's been hard. They have their own side effects. The other option is not to do chemotherapy and to take care of you, keep you comfortable as best we can, and to support you to live as best you can for as long as you can, but not to continue with treatment directed at the cancer. Those are really kind of the two ways to go here. Now, you asked me about time if you don't take any more treatment.
Yeah.
Is that something you want to talk about? You feel up to doing that?
Yeah, I need to know.
Okay. You told me, we talked on the phone yesterday that you're spending more and more time in bed. That you're just not, feeling up to things. Your appetite's fallen off. When patients get to that stage of their cancer, it typically means that time is getting short. And kind of based on cases like yours, I would say we're looking at a few months, 2 or 3 months, something in that range. Has that come as a surprise to you?
Not really. I really felt deep down that the treatments weren't working and that my time was pretty short. No, I'm not really surprised.
Okay. As you think about the different options, is there anybody who can help you make these decisions? Family members, clergy?
I've had good support. I've talked to my children about it. I've talked to my pastor about it. And they're very supportive. They really just want me to be comfortable too, so they've been really, really helpful.
Okay. Well, one of the things that helps people make decisions at this time about kind of doing treatment, not doing treatment, is if there are particular goals they have. Is there something that you're trying to get to, a family event, birthday, anniversary, something that is real important to you right now?
Well, there's nothing as far as a special event like that, but I would really like to try not to keep coming back and forth to the hospital. That's just so wearing. But it feels like you're kind of giving up on me then, I think.
Does it, I guess the question is, do you feel like you're giving up on yourself? Which is very common. When people are thinking about stopping treatment, they feel like they're giving up or letting people down. From the first time we talked about this, we talked about the fact that we didn't really have a cure for this. You've been through a lot of treatment already. Treatment hasn't worked. So I don't view this in any way as you giving up. Just the opposite. It seems like you've really been, sort of fighting this. And now you have some other goals. It sounds like your goal at this time is you don't want to come back and forth to the hospital. I assume you have a goal of working to keep you comfortable and living as long as you can, as best you can. And I think if those are the goals now, then it doesn't mean you're giving up.
Right. That makes sense.
Why don't you think about things? And, you certainly call the oncologist if you want to get some further details about more chemotherapy. Talk to your family, and let's set up a time next week to sit again and meet. There are some other issues I want to talk to you about at that time also, but we don't need to do everything right now.
All right, well, I just really appreciate you being honest with me. I think that really helps a lot. It really does.
Okay. All right. We'll work on this together.
Okay. Thank you.
Hi, Miss Johnson.
Morning, Doctor.
Well, there were things you were here last week. We had that long talk about kind of where things are, and you were going to go home and think about kind of what you were interested in, more chemotherapy, no more chemotherapy. How do you stand today?
Well, I've had a chance to talk with my children, and they've been really supportive. I think it's time to stop the chemotherapy. I just really want to be comfortable. I don't want to come back in the hospital, and I just want to be at home with my family. And they've been real supportive about that.
Okay. And as we talked about last week, I think that's a fine decision. I fully support that, and will help you try to meet that goal. I mentioned last week that there were some other issues that we needed to talk about. One of the issues we need to talk about is kind of how things are handled when your heart stops. This is an issue that many people want to talk about. You may have seen some things on TV. Paramedics get called, and they'll come to your home, and they'll, try to resuscitate you. They may have to put a big tube, about yay long, down your throat, hook you up to a breathing machine, give you medicine in the vein, may have to compress your chest to get your heart started again. Is that something you think you'd want tell me how you feel about things?
Well, I would think that I would want everything done to try and keep me alive.
Everything? I mean, you sure that you want all that stuff done? You know, it's a lot of stuff.
Yeah, I think I'd want everything. I mean, I have cancer, but I'm not dying yet. So, yeah, I think I'd
Okay.
want everything done.
Okay. Well, I think we can do that. And, there's some other issues I think we need to talk about now as well. Okay. Hi, Ms. Johnson.
Good morning.
How are things going? Last week when you were here, we talked about some different options, and you were going to go home and think about kind of where you were and think about whether or not you wanted to do more chemotherapy.
Well, I had a chance to talk with my children and told them that my thoughts were that I would like to stop the chemotherapy. I've just been feeling so awful and it's not helping. I told them that I really just want to be kept comfortable and that I don't want to keep coming back and forth to the hospital. I'd like to be at home with them. And they've been very supportive with that decision.
Yeah, that sounds like kind of where you were at last week. I think that's a good decision for you. I think you have some clear goals of what you want. I think it's a good decision. And just so I'm clear, at this point, your goals are you want to be kept comfortable, you like to spend your time at home, you like not to be in the hospital. And I think we can work to try to meet all those goals. I think one of the things we often talk about is sort of what happens at the end. And I want to let you know that I'm not going to recommend any kind of breathing machines, any form of artificial life support, when your heart stops. And I wanted to sort of touch base with you on how you felt about that.
Well, I'm not sure I understand. I thought, like on TV when you see someone's heart stop, they do CPR and they put that tube in their throat and they always come through, so.
Right. The procedure that you see on TV was really developed for patients whose hearts stop suddenly in the middle of a heart attack or around a heart attack. And in those patients, there's a pretty good chance that with the procedure, they can get the heart started again, and if they get over their heart attack, these patients can go on and lead relatively normal lives. The procedure was never developed for someone with cancer who's dying from their cancer. I don't think that putting you through that procedure would really meet the goals that you have.
But it sounds like you're giving up on me.
Right. You've again talked about what your goals are for the time that you have. And it's my recommendation not to go through this procedure because I think if we do that, it will only prolong your dying in a way that wouldn't meet your goals, in a way that I think you want. It wouldn't allow you to have your life end in the manner that you've discussed with me as something that's important to you.
Well, that makes sense. But, and that'd be okay. If my cancer gets better or starts to shrink, though, I mean, can I change my mind once I've already made this decision?
Absolutely. We can always talk about this again in the future.
Okay.
Whatever comes up in the future.
Okay.
Okay, fine. Now, there's some other things that I think we need to talk about also.
Okay.
Ms. Johnson, it sounds like you've made a decision. You want to stop chemotherapy, and I think that's a good decision. I fully support that. And just so I can reiterate, it's clear to me that your goals at this point are to be at home. You want to be as comfortable as possible. You'd like not to have to come back to the hospital. Is that right?
Yes, that's right.
Okay. One of the things I always talk to my patients about at this point is how I can best support them in the home and provide them the best care that we can. Tell me how things are going for you right now. Are you able to do your shopping and cooking and cleaning?
Well, not as well as I used to. There are some days where I'm just so tired I barely can get out of bed. And there have been more of those days lately. But my children help me. They shop and clean when I just don't feel up to it.
Okay. What, one of the things that I think is very helpful is what we call home hospice care. Now, it's something that I would recommend we get started now. Do you know what that means, hospice care?
Well, I think it means people who take care of the dying, and I'm not sure if I need that right now. I mean, my children have been helping me.
Yeah, and I would agree you're not really dying right this minute. I don't expect anything to happen this week or next week. And hospice really isn't designed for people at that point. It's really designed for people who have months to live yet, and they can provide a variety of services. You told me before that your parents died of cancer. Do either of them have home hospice care?
No, they both died in the hospital.
Okay. The kind of services that hospice care can provide are a trained nurse who's available 24 hours a day if you're having a problem, can come out to the home. A social worker who can work with you and the family, dealing with the issues that are going to come up over the next few weeks to months. A chaplain who can visit. Volunteers, if you need volunteers to help manage things. And perhaps what I like best about it is that it helps me do a better job caring for you. I get somebody out to the house who's got trained eyes and ears and who can tell me how things are going. You've already told me you'd like not to come back to the clinic if you can avoid it. So this can help meet those goals. How does all that sound to you?
So all those people would be coming to my house?
Well, as many as you would want to meet whatever needs there are. They don't all have to be there, and they're not all going to be there at once. But you can sit down and tell the hospice agency how you like, who you need to visit, how often.
Who pays for all this? Do I have to pay for this?
I already checked with your insurance company, and they do have a hospice benefit that will cover these services.
Well, it probably would help my daughter. It sounds like she's really having a tough time with this, so they might be able to help that way.
Sometimes patients have concerns about what would happen if, things aren't going well at home, can they ever come back to the hospital? I can let you know that, we try to do things in the home as best we can. Sometimes, though, a problem may come up, and even under hospice care, you can still come back to the hospital. I'll still be your doctor, both when you're at home and here, so that's not going to change at all.
Well, that's good to know. That's good to know.
So there is some flexibility. Why don't I do this? I can call one of the agencies and have them give you a call, and they'll make an appointment to come out to the house and see you, and then they can discuss it, answer your questions.
I think that would be fine.
Okay, great. Let's go ahead and do that.
Okay.
Now, there's still a couple of other things that I wanted to talk to you about today.
I wanted to talk to you about this patient who Dr. Malinzak and I took care of. He showed up in the waiting area, kidney pancreas transplant recipient. 3 months into the transplant, he has some ulcers on the legs, on his feet, which have not been healing, and he was seen by another clinic. I found him out in the waiting area, all huddled up in his wheelchair with a young son who drove him to the clinic. His wife was at work, and I asked him, what's happening? And he tells me that, I'm going to have an amputation of the leg. Now, that is actually a life-altering procedure. So I said, why are you waiting here? Who knows anything about it? So he says, my wife's coming. The next thing I know, Gail, my coordinator, calls me, and she tells me that the wife is very upset. We have to talk to her. The wife comes, I called her, got her into the clinic, because I needed to give her information about what's happening. I didn't know anything about it, so I hadn't taken care of him that particular day. So I got her into the clinic, gave her something to eat, made her comfortable, got him into the clinic in the area where we give infusion so that he's comfortable there with the son. And I picked the phone and I speak to Dr. Malinzak. I said, do you know anything about this? Because the clinic where he came in from did not, there was nobody there, the nurse was not there, the physician who had told him that he'll need an amputation was in the OR. The team that referred him to that particular department also was not informed about the decision. So the wife is upset, the patient is there upset, not saying too much. After this procedure, which was planned on him, and he is NPO, kept NPO because there is a procedure that afternoon, and he said, what procedure is going to happen? So Dr. Malinzak picks the phone, talks to the service and says, gets the information. Yes, the patient is going to have an angiogram. Patient is going to get admitted. The patient is going to be seen by vascular surgery, and there is going to be a possible amputation. But the angiogram is not going to happen today. So I said, okay, let's talk to the wife about it. I told her, look, your husband needs to be admitted. One. Number two, we need to know the extent of the disease. I think that's why they were planning on doing an angiogram. Number three, once you're in the hospital, we will see what your blood counts look like, what everything looks like before any decision is made to go further with your procedure. Dr. Malinzak spent the next day 2 hours talking to the patient about what's going to happen to him. She had spent a lot of time with the wife, the family. He calls me in the night. I spoke to him and his wife. The next morning I spoke to him. The next afternoon I spoke to the husband, the wife, and there was a child there, all of them. It took a long time to get them to get this information in, but it was done the way we wanted to do it so that at least they start accepting it. Patient was discharged and had the procedure after that weekend. But just getting him from that waiting area, it was amazing that he was just sitting there and the wife was so upset. Problem that bothered me was, one, there was no communication. Two, there was so much of frustration. I was frustrated. Dr. Malinzak is frustrated. The wife is frustrated. The patient is all passive. We had to salvage the issue, which we did. In a whatever way we wanted to patch it, we had to patch it up. Ultimately, he did undergo the amputation. He is now in rehab, and he's coming to see us. Again, the main thing they wanted was there any support? Is there, am I going to do better? And how much is going to be the recovery time, and what's going to happen next, and why did these ulcers occur, and lots of questions which were not totally answered, and then ultimately we did. So that was the tale I wanted to let you know. There was so much of distress in the family. The second is the interesting story where a young lady who I saw in a clinic in Lansing, Dr. Denny was with me, congestive heart failure, 10% ejection fraction, has CKD stage 5 and wants to be evaluated for a kidney transplant, referred by one of the physicians there. We saw her, we discussed all the issues associated with her care and what are the likely complications that are going to occur in making that decision. And a part of it was an evaluation by our CHF team. So patient was referred, and we forgot about the whole thing. A few months later, there was a phone. We discussed her in the selection meeting, and she was turned down because there was a low ejection fraction, and the likelihood of her having a successful and a good outcome with a transplant was poor. And so we turned her down, and all hell broke loose. The sister got upset, threatens to hit the airwaves. Dr. Eshelman just said, negative campaign against us on the Facebook. She is a musician of some kind, so she was all out to go against us. Lots of threats. Our PR department talked to them several times, all unpleasant. So we needed to resolve this issue. First, I had to get what was the information. The first goal was to get all the information. What does the patient know? How much does the patient know? What are her expectations? And her readiness to hear this bad news. So I went to Lansing, spoke to the patient, Her sister was interested in her care, so she lived in Detroit, but she came to Lansing. And we had the meeting, and I was there. Dr. Denny was going to come into the room if I wanted him, but I sat there and I spoke. I had seen her, that's the day I saw her the second time ever, but they were there to listen to what I had to tell. And so we spoke. The first thing was, what is the information the patient wants to know? And second goal for me was to provide her with some intelligible, information. And this was one, your transplant is not going to do well because of a low pump function. That was not the issue that she was bothered about. She said, somebody called my social support very poor. So I said, I think there was a misunderstanding. So we clarified the misunderstanding. I told her that her kidney would do better once her heart got better. And if the heart function got better, maybe it's a successful transplant. In the presence of an unsuccessful transplant, or if the transplant failed, she will have issues with going back on dialysis because there is a burden of inflammation that occurs, and life is not good on dialysis after a failed transplant is there in the body. So these things were explained to the sister, to the patient. There was our oldest son was there in the clinic that day, and a young daughter. The thing was that I had to give her, okay, you now will have to do some things. What kind of support does the patient have, and the support that the sister can give? Talked about that in detail with her, and we had a plan. I said, okay, I think the most important thing for us to do here is, let's see if I can talk to the referring physician, the primary nephrologist, talk to your cardiologist, talk to your primary care physician, and see if you can get into a cardiac rehab program. You have just started peritoneal dialysis, and you are already beginning to feel better. Her exercise tolerance had improved some. So I thought, okay, this might be uremic cardiomyopathy, and she's going to get better. So we got her to go through that program. That's the last I have left her. I said, we will evaluate you once you have gone through this graded exercise program and you feel better, your heart function improves, and I promise you we will see you again. So we are going to get her back for a second evaluation. That seemed to satisfy the sister, the patient, the family who was sitting there, and since then all the threats have stopped. That was a huge lesson that we learned, how abruptly turning down a patient by phone, which the coordinator did, and sent a letter, which we did, and that didn't go well. It required a full conversation with us. So we decided, I think we need to change a few things. So up front, I think we should clarify what kind of bad news is possible. Dr. Eshelman has already gone through that. I need the family to be listening, not just sitting there and not paying attention. They need to listen in to what we are saying. What are the likelihood of things going wrong? And that conversation needs to be documented. I had a patient once with FSGS, which is a condition of the kidney, where you spill protein. I told her it will recur. She was alone in the clinic during the evaluation. 6 months into her kidney transplant, it recurred, and she gets admitted with all kinds of complications. The mother is in the room throwing things around the room, the patient's mother. Nobody told me. The patient was told about it, and I documented the conversation in my note. The mother wasn't there at the evaluation, but she just refused to. Why did anybody not tell me that this condition can recur in that transplanted kidney? So we need to have a family to pay attention to what we are saying and go slowly with them and tell them exactly what are the pros, what are the cons, what are the likelihood of things going wrong. And it has to be there.
How much do they retain if they pay attention from what you're telling them?
I think they don't retain a whole lot. That's why I think, can you tell me what you understood today? Is another question which most of us don't ask, but I think we should ask them. That what do you know about what I told you today? Can you reiterate back to me?
Suppose you give them 20 points of information. Will they rehearse 20 points of information?
I don't think so.
So what would be then the thing to do?
I think that the thing to do would be to supply, I draw things down so that they understand better, or I give them information. I tell the primary nephrologist, I think she needs a lot of education. I tell them upfront. My social worker, I tell him, I think there is an issue here. Her understanding is poor. We need to re-educate. Education of this patient is very important. So I tell them to watch that video which we give them. And I tell them just don't leave it in the corner in the house. It's sitting there until the day of transplant. I think you need to watch that, and any questions that come up. Here is my card. Here is the coordinator's phone number. Call and ask us those questions, and we will be there to answer. Some patients call back. Most patients don't. That's the experience I've had.
So if I'm understanding, do you tell people that they're not a candidate over the phone? I always sort of struggle with this. If you have somebody who's many hours away, is this something that you're advocating that has to be done in person, or do you tell them this over the phone?
That is again something which we are now in the process of developing. When I see the patient for the first time right then, and particularly because they are coming from somewhere in the thumb area of Michigan, I ask them upfront in the clinic, if for some reason during this testing process you are considered not to be a candidate for this kidney transplantation, how do you want to know this news? Do you want me to call you down here with your family and talk to you about it, or do you want to hear this on the phone? Upfront, I'm asking them. And some patients, oh yeah, phone is okay with us. Others, they say, no, I want to be here and I want to know the reasons why. And they tell us. So this is the most recent, I have a smart phrase created which I'm using in the clinic to document this conversation. The same thing applies with, you now have a rejection in the kidney. If there is something like that, post-transplant news, how do you want to know? By phone, or do you want to know it in person? Face-to-face meeting with the provider, with the team. And quite a few patients are able to tell what they want, because I have patients from Ypsilanti and they don't want to travel the distance. They say it's okay if you tell us by phone, we'll be able to hear, as long as we know everything clearly and the conversation is there with the provider. Some statistics about breaking bad news. 55% of the providers ranked how to be honest with the patient and not to destroy hope as important. Another 25% thought that dealing with the patient's emotions was important. 10% ranked finding the right time as a problem. I found that hard to believe, but yes, it's there. Less than 10% had formal training. That's why Maria is going to be helping us in the future. 32% had the opportunity to, during their training, to just listen in to the any bad news that was broken. 52% of the providers had no plan or strategy in mind when they went to speak to the patient. Now, things have to change as far as we are concerned. I think that's very important. So 9 tips to do better. I just found this. I don't know where the references are there. Prepare yourself to feel badly, because if you don't feel bad, there's no way out. You're going to feel terrible about breaking that bad news. See, doctors are trained to give good news all the time, but when delivering the bad news, that's not what happens. Okay, the patient is going to feel bad. And if we don't recognize this as normal, then we are actually making them and giving them good news, making them feel good about giving bad news, then we are actually being counterproductive, and potentially it might be a deleterious effect on our doctor-patient relationship, plus in the long run we would have added pain to this patient's management. Secondly, I think set the context and rehearse your part. To talk today, I had to rehearse it several times. Same thing, if I have to speak to a patient, I go through the dialogue in my mind, and how am I going to speak to this person? Deliver the news equivocally and very clearly. We don't beat around the bush, we don't soften it, because if we do, then the patient gets a wrong message. I think we have to tell them clearly as it is, and that is very important.
Unequivocally.
Yes, unequivocally and clearly. Give them time to for the message to sink in, because they're going to soon start asking questions, and we have to be prepared to answer those questions. And again, very clear answers have to be given. Never destroy hope. That's very important, because when quantity of life is an issue, then quality takes precedence. I think the cardiac program knows that more than anyone else. And there is nothing worse than going through life without having hope. That quality of life is gone if you don't have hope. So never destroy that hope. And express your commitment and for support. So that means I'm going to be there with you throughout until the end. We will support you and keep you comfortable. Have a plan so that the patient knows and has the confidence that they are going to be, yes, I'm going to bank on my transplant team. They're going to take care of me. They are really good, and they will handle this problem for us. So that's very important, the 9 tips that I thought that will help. Very important, we have to be empathic. Empathy is so important because 78% of the patients in a study prefer an empathic professional and rather than a distant expert or an emotionally burdened expert. 9 to 10% thought that these are the kind of people they preferred, but no, they want empathy from their professional, from their care provider. 52% of the providers find sympathy to be the most, empathy, sympathy to be the most difficult aspect of spikes, the protocol that we use. I thought I'll make a flashcard for everybody with the spikes on one side and the suggested empathic script. It's not enough. I think we need to get a whole lot of training, but just for starters, something which we can carry in our pocket, a few words which we can use on a daily basis with our teams. When we are talking to the patients, could you explain to me what you mean? You said it frightened you. Things which we can get the patient to open up and talk to us about it. We have to be sensitive regarding culture, ethnicity, and religion. I don't mind asking Hasina to come, and come with me when I want to break news to an Arabic patient, because I know that she'll be able to, with her around, I'll be able to do it better, and maybe the patient will be more comfortable. Or if ask Gail, if Jonathan needs some bad news to be broken, I ask Gail to step in and we do it as a team. Or somebody who is older. I have Julia. I have Julia. Dr. Venkat. Julia is 95 and she got a transplant 30 years ago. She's 95 today. But the only person she has on her mind is Dr. Venkat. How is he? So if I have to break bad news to Julia, I would rather use his help because I know they can connect. And there is always this language barrier, in which case then you have to have the interpretation service, talk to the interpreter, and because whatever the cultural and the language brokering that needs to be done is done in the right way, we have to prime them previously what kind of news we are going to break, and then talk to the patient. Nothing matters more except knowing that the patient, what are the patient's preferences and how well that needs to be taken care of, even if there are cultural barriers or any barriers. Who should give the bad news? I thought in letters, Dr. Eshelman has gone through this slide. Again, it depends upon the gravity and the type of the news, patient's proximity to the transplant center, patient preference, presence of family members, and the level of comfort of the patient and the provider for us to give the bad news. And should it be given by the coordinator? Some kind of bad news, yes, because the coordinator seems to know the patient better than I do. I have seen the patient once, maybe twice before the transplant has occurred. But the coordinator has spoken to the patient probably some 10, 15 times, and they seem to know what's happening in their lives much more than I do. But then, if it is a attending physician giving the news, then it's coming from some kind of an authority. A middle ground, maybe the coordinator and I should do together should break in the bad news. That would be probably a compromise for us. Referring physicians know their patients well. Sometimes I just call the referring physician and I tell them that, look, this patient has issues, and you know that, and I know that, and this is what we found, and he is going to take this news not very well. So I think we should get together and talk about it and do it. Logistics are a little difficult with involving a referring physician in this conversation, but in the future, I'm hoping to be able to do that. With regards to the kidney transplant program, the major examples of bad news are turned down for listing. Medical, surgical risks, psychosocial risks. Generally, right now it's being done by the coordinator via phone and then followed by the letter. I think it should be done as a team effort, the physician, the coordinator, the social worker, with a little help from the referring physician. I think it will go much better, and we will not have this backlash which we get now and then, to reduce that. Plus, I think that the patient is comfortable in the presence of a team. Now, if they are living far away, that's not going to happen. Maybe in the future we can do it through telecommunication. I don't know. It's a possibility. But then telecommunication, telephone messages, you know, that physical cue, that empathy which we can have in the room is lost. It's not there. And so the presence, physical presence, is so important. What about listed patients who are placed on hold? By the time they come to us, there is already a diagnosis of malignancy that they know about, and their wait period is what matters with us. So then we have to break the news to them that they are on hold for X number of years, or if they have had coronary artery disease, why did they go on hold, or if they have an issue with weight. All these can be done via phone and a letter, but face-to-face with the team is the best way to do it. Post-transplant complications, now that's where I'm very comfortable, because I have been seeing this patient for so many months or years, and so if there is an issue that occurs, we discuss this in the clinic very comfortably with the patient, and most of them seem to understand and know why. Palliative care, hospice post-transplantation. We've had people who die from overwhelming sepsis, malignancy, and once there is death, take care of the family. Everything is done by a team of physicians, the inpatient team. My coordinator is always there for me to fall back upon, because my post-transplant coordinator knows the patient the best, because they've had this, get me this drug, get me this prescription, can I have this a test done, that test done. So they know the patients very well. I grab them in order to do this work. Case manager, psychosocial support, chaplain, hospice staff, they are there to help out any news that is in the hospital. Unacceptable living donor, that's another news that we need to break. Usually is done via phone by the coordinator, and the physician who is in charge of the donor program also talks. Primary non-function of a living donor transplant, this is very profound, because it's both the donor and the recipient are affected here. For the recipient, they go back on dialysis, and that's something which they did not look forward to. But for the donor, donor has now lost a kidney, and there are issues. We have to take care of that donor, his psychosocial issues, and it's quite hard on the donor when that organ is lost. And at the time of transplantation, aborting the surgery, well, most of the times this news is broken by the surgical team, and they seem to take it well. For telephone conversations, again, certain type of news can be given by phone, and for others we need physical presence in the clinic. Always use the spikes model. Sharing information over the phone, as you know, is awkward because of the lack of physical proximity and the inability to read the nonverbal cues. Lots of challenges. Always have a follow-up visit. For people whom we don't know, sometimes my inpatient rounder does not know the patient or the family, and we need to break the bad news. We, on the phone, then we make sure that we know who we are talking to, introduce ourselves, and for phone conversations, we ask where the patient is, like if they are in a mall or shopping somewhere, that's not a place to break news, because first of all, it's noisy, they might not hear you well. It's good to have them somewhere where they are in their own surroundings. Ask if somebody is there, encourage the patient to call a family or a friend, acknowledge that you rather prefer in person, to talk in person, and then fire the warning shot, break the news, but have a plan plus a conversation. The patient should be able to get back to us after the message is given by phone or the conversation is had by phone. We should get their contact information, plus they should be given our contact information. Immediately, no questions, but later on there will be a lot of questions which we will be answering. So my last slide was going to be this. Objectively structured clinical experiences is something which has been developed by our team here on the right-hand side of the room. We have this done at the Henry Ford, the Simulation Center, but the curriculum for sharing this bad news is offered to the first-year residents currently, and they are being, it's being developed as a curriculum for nurses, for fellows, and I think we need to go through this much more than this introductory talk that we are giving. There's a technique which we need to learn and go through. People will forget what you said and will forget what you did, but they will never forget how you made them feel. That's what I can tell you.
I just wanted to highlight that there are resources for staff if you're overwhelmed with this kind of process, and resources for patients. So we need to help our patients get through this. And as far as a future direction, I think each transplant team should look at what are the kinds of bad news that are given, how they're given now, how smoothly it's going, and look at what kinds of, how to use this model in the context of a particular organ system. The issues in kidney transplant when they have the option of going back on dialysis are different than a life-sustaining organ like a liver or a heart, where if you get turned down, you don't have a dialysis backup. And I think it's also important to look at making sure that we are giving people realistic expectations. Even if they come to us and they don't have realistic expectations, we need to add that step. We see I see lots of patients who come and they say, I'm on the list, when they haven't even been evaluated yet. Or my doctor thinks I should be transplanted, and they think their referring physician has total control over this process. Often the referring physician actually is wanting us to give the bad news, and they know that the patient's not really going to be an acceptable candidate. But you know, if we're comfortable with this process, we do have a responsibility to do this. But each team needs to think about who should give what kinds of bad news, and make sure that those who are designated are comfortable and competent with this process, and that we have done the step looking at the plans for the future, so that it's not just drop the bad news, but okay, where do we go from there? How can we answer questions? I also want to thank Dr. Koyan Mims, who's our fellow in health psychology. She helped us with this project, but behind the scenes. And also Les Bricker, who is an oncologist here at the hospital. He is very experienced with giving bad news, and he's the one who has taught the residents each year on giving bad news. So, thank you.
Thank you for a wonderful presentation. We'll take some questions, and maybe I can start by asking some questions myself, because this is a subject that I always think through, and mostly because I put myself in the patient's shoes and I say, how would I want to hear it? And one thing that comes to my mind is, number one, the words that we use. I'm always challenged with this. When we tell people risks outweigh the benefits, poor social support, if you tell me poor social support, I'm offended. You know, I drive my dad to the clinic 2 days a week, he one of 3, but I drive him nicely and I'm there with him 2 days a week. Is that poor and sufficient? So when I hear poor, I get offended. Then I'm angry, and then I'm going to react. So the words risk outweighs the benefit to whom if I'm going to die anyhow. What does that mean? We use that. Again, how do people hear it on the other side? So one question is, what are your opinions about the words we use? And the second thing is, we talked about the documentation. I can't remember the thing, even myself, when I go see somebody. How about for transplant? And why not record it? Or why not have a transcript of some sort about summarizing what we talked about? I don't do that now, but I like to do it. Any thoughts on these two issues?
See,
ahead.
go ahead.
No, you go ahead.
So with regards to the documentation, we are working with Epic, and everything is documentation. So putting in a one-liner or two-liners about what we spoke to the patient, it's very important, because 3 years later the patient has come for a transplant. At least I can go back to my note. What did I tell this patient 3 years ago? Because I'm not going to remember 3 years ago. I can't even remember the patient's face, because I've seen the patient once a year, maybe. Second time another provider has seen, third provider has seen, and now the patient has come for a transplant, and then there are issues. So the way I did it was by just documenting. In the past it was easier. You dictate, chug, 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 you can talk. But now it's all typing out, and we try as much as possible to document whatever conversation we've had with the patient, because otherwise it goes around and it comes to bite us
So you
when we
recommend
don't.
scripting in the after visit summary?
Absolutely.
Okay, thank you.
Absolutely.
How about the other question regarding the use of words?
Oh, see, that's where I'm very poor at words, am I? I don't know. But I have some here. I don't
Like
think
food
this is
social
going to be
support and all these things.
right. I mean, I think we have to go back and look at our letters. We have to go back and look at our scripts of how we are talking to the patient, and we need to tell them in a very sympathetic but firm way what we have to put the message across, and clearly that this is our expectations, these are your expectations, let's meet them here, and these are what we expect you to do, and this is what you expect us to do, and this is what we will do together. I think that's the only way. I think conversation, back and forth conversation. This morning Dr. Kim and I spoke to this lady who is going to have her bladder taken out. So we went through this long talk about what are the various options, and I'm going to have that documented in my note this evening. When I'll go back and get my thoughts together, I'll put that down, because in 3 years' time, if she's on dialysis or something else goes wrong, this conversation, I'm not going to remember it. I have to put it down today while it's fresh on my mind.
Dr. Franklin?
To answer your question about you and words, you are never at a loss.
I know.
I can assure you. Now, the most time we spend with the patient is during the initial evaluation. And I think that's a very opportune time to tell the patient what is realistic about their situation. And I personally believe that I emphasize the negative things about the patient more than the positive things. And I put in enough doubt in their mind, they may not be the latest
Candidate.
candidate for transplantation. Because after that, you seldom see the patient until they're coming in for the transplant, or they've been turned down, and so on. So I think it's very, very important, the first meeting with the patient.
Yes.
If you have serious doubts, emphasize that, and also emphasize the fact that they are not yet been listed. They have not yet been listed for the transplant, and it's a selection committee decision, which will come in the future, and so that they don't walk out of the room thinking that they are listed. The second thing is, somebody said the referring physician wants us to break the bad news, which is true. But I would emphasize the fact, never put the referring physician
In a spot.
If you discover something which the referring physician has overlooked, for example, you discover a lung mass on a chest X-ray, or hepatitis B surface antigen is positive, call the referring physician
And inform them.
Give him a heads up and ask him, do you want me to break the news, or do you want to break the news? Because you can get into a very awkward situation here. And the third point I want to emphasize is that when you turn down someone, tell them they have the option of going somewhere else.
Which we do.
And that should be emphasized, and that comes under not destroying the hope.
Yes,
And
which
it
we
also
do.
tells them that you're humble enough to know that you're not always right, and somebody else might view their problem
Correct.
differently.
Lee?
So I actually wanted to address a few questions that you raised. those are very, very important aspects of delivering bad news. I think that maybe with Dr. Eshelman or Dr. Bricker, come up with these words or phrases which are not threatening. If you ask the patient why, then all of a sudden the patient's on a defensive. Just like you said, for social support, well, the patient's on the defensive again. So there are better ways to say certain things, and I think that's what you may have been trying to say. And maybe Dr. Eshelman or Dr. Bricker, who have a lot more experience with these patients and with words, can help us with that, because that is important.
Script.
And then in terms of what you tell patients and what we document, it is important for us to document what we've said to the patient. But at the end of the day, I think that the patient usually doesn't hear what we
Half
say.
of what we said.
And then when we come back and say, well, we told you that this could happen, well, they're not
Prepared.
They're not going to say that, well, oh yeah, you're right, you did tell me that, and well, yeah, silly me. And they're going to still be angry, and so we still have to understand what we told them, which is important what Dr. Patel was saying, but I think it's also important for us as the care providers to understand what we told them and then try to refocus our
On the same.
conversation. And that's not easy, and I'm not good at it, I'm not a person, but I think that's important for us as a group to understand.
And then everybody should be on the same page. The coordinators, the physician, the surgeon, the caregivers, everybody should be on the same page regarding that consistent message. Because if the patient gets different messages from different parts of the team, then there is total chaos.
There were some studies done that for people undergoing surgery and otherwise, where when they documented those conversations about the risk of surgery, and then people took the documentation home to review with family and significant others, so there was a significant reduction in anxiety and some better outcomes in relation to self-care, just based on the fact that people were ready and were able to rehearse and understand what the responsibilities were, what was told to them, just by being able to go back and review it under a calmer head in a different setting, and share with their family members. One question just before, and the way I think about it a lot of times, if I were the one getting the services, I want to deliver it at some level my way. Why not just ask me, how would I like the information delivered to me? When I come in, when I get the evaluation, like say, how would you like your steak cooked, or how do you like, information delivered to you? Regarding your labs, regarding rejection, regarding this, because these will come along the way. And it becomes more of a preference setting. And then as you develop a relationship with that person and their family, you kind of understand where they stand with those issues, whether they're remote or close. I just want to toss that out, that when we're formulating this protocol, having an understanding of where people stand with the community. Like this person told me one time, I came here so many times, I was referred to a doctor. Are you going to get me one of your nurses to call me? Now, of course, that was offensive, but he was expecting to speak to a physician, and that was his expectation. And another person would tell me, Doc, I haven't seen you, I don't know who you are. Can you give me the jacket, please? So, and the other way, he's offended that I'm talking. He wants the nurse to speak with him. So it's one of those things.
As far as that goes, we did talk in the focus groups as far as how can we ask and document how people want the information. And we're looking at, is there some way in Epic that the rest of the team knows that they want their coordinator to call, or they want the message by phone instead of dragging them down here for a 5-minute bad news conference or something. We haven't figured out how to do that so that everybody gets the message, but it's probably good to ask that question anyway. One sort of parting thought, when we think about communication, part of it is giving the information, the other part is receiving it. And yes, we can document and say, I gave it, but we need to know, did they receive it? And one way is asking them, and in little bites, if you're telling them 20 things, ask them after each thing, not after the whole 20, because nobody's going to remember the whole 20. But making sure they understand each thing. And maybe on our after visit summaries, which, maybe this is going to take more time and it's going to be a frustration, and I'm not telling you have to do it, but if your after visit summaries do include what you really want to make sure that they got the message, that's another way. there are going to be more and more issues because some of our patients don't read well. So I don't know what they do with the after-visit summaries.
Right, they don't
But
even look
we
at
do want to make sure that the information is received and at least find some way to find out, you know, yes, we gave it, but did they receive it and did they understand it?
What do you think about email? Because I have several patients that live 2 and 5 hours away, and they will email me questions, and I'll, you know, and it's convenient because you can start your response. If you get distracted, you can save it, come back to it, and I'm usually able to respond in the same day. And I save the emails, and I actually have started pasting them and actually putting them into the electronic path where I can sort of like a telephone sort of.
Okay. Yes.
A very good rule of thumb with email, and it's not just with bad news, but even if you're giving someone feedback in the workplace, is if you have to see their face with the information you're sending, don't send an email.
Right.
It's real simple, very basic, but that way, if you think you don't know how they're going to
Yeah.
understand it, then don't send an email.
I mean, most of the
Maybe
time
follow
it's
up with the email, but at least have a phone conversation.
I didn't realize that that Dr. Bricker is here,
Yeah,
and
he's
I introduced him as the king of giving bad news. Do you have any thoughts or things you wanted to?
Good news is for us and bad news is for you.
Like you say, words matter, and it's often not only just what you do say, but what you don't say. You know,
Right,
and
the
so sometimes
personal
you've all learned what you
cues.
shouldn't. You're also commenting on things you shouldn't say because they're the wrong things. So, and it's a skill, and it's something that takes practice. And I had the misfortune to practice as an oncologist for 25 years, so I gave a lot of bad news. I made a lot of mistakes, learned from a lot of from the mistakes, I hope. And then there's things like spikes, ask, tell, ask, nurse. Kristen Chastain is teaching a wonderful technique of open-ended, empathic questioning, things like that. And that just it's a skill, it just takes practice. You're not going to get it the first time. As far as what do they hear, I used to have patients bring little tape recorders in. And initially I was very nervous about it, but I realized after they heard the word cancer, they didn't hear anything, and they would go home and play that tape 100 times. And they would play it not just for themselves, but for their family. And that it was never threatening. It was just, like you say, you were uncertain what they actually heard. You know, it's often important to ask, to get an invitation as part of spikes of how do they like to get the information? Are you sort of family that likes everything, or do you want little bits, or is there somebody else you want to talk to? And realizing that sharing this information is a process. One office visit may not be enough. And that it may not be until the second or third visit that they actually truly understand everything that you're trying to tell them.
I have a question. What about those people who shy away from telling their family about what they are going to go through? You know, and they don't want to tell their family, they want to buffer them from that bad news. It's so counterintuitive versus, I think it does not allow that healing, that process of having a, you know, support system in the house.
Ask them one.
I could ask them.
What are you afraid that they will say? And maybe they're just afraid of something and they're unsure. Often I get it the other way around. So the family says, don't tell him. You know, and the best thing to do is say, you know, what's been your prior experience? What are you afraid I'll say? And go from there.
Yeah. I mean, one of the things that I always want to emphasize, and we all experience that, people come to us because there is a life at stake. They're either going to die without the transplant, or their life is not as good without a transplant. So there is so much hanging on this. This is a lifeline, and it's basically the end of the line is hope for them. And so whatever we say or tell or deliver, it's in the context of that hope. And if they don't get the positive sense of the hope, there is a major disappointment and a whole sequence of mental, psychological, dynamic events that occur internally or within the relationships and what have you. Now, you will be on the receiving end of their reaction and also of what you deliver. So the better you are in tune and connected with how they feel and sense and act and react, the more you're able to sense that and adjust to that with skill and learning, but it's going to take from you. And this is where I think understanding that doing it well is engaging but is consuming at some level. And therefore, we need to develop a skill to how to go back and recover from an encounter that really took something out of you today because you cared for that person. After second transplant, that person did so much for us, and we can no longer help out. And this is what Ann was mentioning. There are these resources, but the resources are predominantly really people, us talking, and then also figuring out a way how there is a cycle of recovery or resilience or self-healing so that you become a resource as well, but you don't want to take it home either. And so realize that it does take something to do well in the domain of giving this kind of news and connecting with people and having a method of recovery as well to be able to do it again. Does that make sense, Ann?
That's a great comment, Marwan. That's excellent, because I think it's really important that in order to do this well, you have to feel, you have to, be empathetic with these patients. But it does take a lot from you. So I think that's a very important to just recognize that. I think that's and Dr. Bricker is awesome. You can just follow him and look at his mannerisms, the way he talks, the way he sits. It's not, he doesn't even sometimes say anything. And the patient just relaxes and they just open up to him.
To the Bricker
So
rotation.
just to follow him for a day, you can learn so much about how to interact with patients who are at the end of life. He does a wonderful job. His team is fantastic.
That's a great phrase. Mike, you had a question?
I learned this also applies to the good bad news, where you say, yes, but we are going to be able to transplant you. Heard from two patients, one who both of them felt like did not have enough information going forward. One was very angry because after they got the word cancer, but yes, everything was lost. So had no idea what to expect and was very unhappy with the process. Another one was not angry, but also echoed, after I heard this word, I stopped hearing everything else. And you can go back to the documentation and say, even teach-back was documented. So the concepts follow through to the good, bad news as well.
Yeah. Thank you. Any other questions?
No.
Well, thank you very much, everybody.
Thank you.